Welcome back to The Explainer. Today we're diving straight into something we all see all the time, but honestly, it's frequently mismanaged. I'm talking about acute viral rhinosinusitis. We're going to completely unpack the guidelines today so you can walk into your next clinical encounter with a crystal clear, highly predictive framework. Let's get right into it.
Okay, let's dive into this. Here's our agenda for today's Explainer. First, we'll nail down exactly what viral rhinosinusitis is. Second, we'll look at the specific clinical features and criteria. Third, we'll tackle the classic viral versus bacterial presentation. And finally, we'll wrap up with the evidence-based treatment plan.
Section 1. What is viral rhinosinusitis? The foundation. So, acute viral rhinosinusitis is strictly defined as the inflammation of both the nasal cavity and the paranasal sinuses. It's absolutely crucial to recognize that dual involvement. Clinically speaking, you can think of it as basically synonymous with the common cold, just specifically when there's a really pronounced sinus component involved. I know it's a super foundational medical concept, but locking in this exact definition really prevents diagnostic drift later on. Basically, you're dealing with a cold that has literally taken up residence in the sinus.
Now, when we look at the actual viral culprits, this almost always follows a standard upper respiratory tract infection, or a URTI, and the data shows that rhinovirus takes the absolute lead as the most common offender you're going to see in practice. But, you'll also routinely see influenza, parainfluenza, and adenovirus in the mix too. Understanding these specific viral triggers is actually super helpful because it frames the rest of our clinical expectations, especially when we start talking about the timeline and treatment.
Moving right along to Section 2, Clinical Features and Criteria, the clinical picture. Now, what's really interesting about this next part is how the source material highlights the EPAS 2020 criteria. It's a massive, high-yield tool because it takes those vague, subjective patient complaints and turns them into hard, objective data. To make a confident diagnosis, the guidelines say you absolutely need to identify at least 2 of these 4 specific criteria. First up, nasal obstruction or blockage. Second, rhinorrhea. And hey, notice that little note saying any quality? That's a big one. It means the color or thickness of the discharge does not automatically dictate a bacterial infection. Green doesn't always equal antibiotics, right? Third, we have mild facial pain or pressure. And fourth, hyposmia, which is that reduced sense of smell. You really got to keep these 4 in your back pocket, because missing them means you might need to rethink your whole diagnosis. And these criteria, they help us build a highly predictable clinical timeline. If you look at the timeline, day 0 is the onset of the URT. By days 5 through 7, you should see symptoms actively improving. The patient is finally turning the corner. And by day 10, we expect full resolution. The whole shebang stays strictly under 10 days. Also keep in mind that a fever during this viral course is typically either super mild or just totally absent.
Section 3. Viral versus bacterial presentation, the diagnostic pivot.
So, the crucial point of this whole explainer is differentiating viral from bacterial. We just laid down the viral baseline, duration under 10 days, clear improvement by day 5 to 7, and mild or no fever. But you have to watch out for the bacterial warning signs. You're specifically looking for a severe onset or that classic double sickening pattern. Double sickening is exactly what it sounds like. The patient gets sick with a standard cold, starts to feel a little bit better, and then boom, suddenly gets much, much worse. If you see that double sickening red flag or a super severe sudden onset, you are no longer in viral territory, and you must pivot your approach immediately.
But, assuming we don't see those bacterial red flags, what's our next move? Well, when it comes to investigations, the guidelines throw up a massive stop sign right here. The approach is strictly clinical. No imaging, no cultures, no routine labs, period. Ordering a CT scan or a blood draw in this scenario is completely unnecessary and goes entirely against established guidelines. Trusting your clinical exam and those EPOS criteria is 100% the way to go.
Which brings us to our final section, Section 4, Evidence-Based Treatment Plan, the resolution.
And this brilliantly illustrates the overarching rule of treatment here. Management is symptomatic only. We are not curing the virus, folks. We are just supporting the patient through their immune system's natural process. It's a beautifully conservative, evidence-based approach that actually protects the patient from the side effects of medications they just don't need.
Let's walk through the do's and don'ts. On the recommended side, we've got nasal saline irrigation, analgesics like NSAIDs or acetaminophen, intranasal corticosteroids, and decongestants. But I really want you to pay close attention to the not recommended column. This is where the major high-yield takeaways are. Antibiotics, antihistamines, and systemic steroids are strictly not recommended. Prescribing antibiotics for a purely viral issue is such a common pitfall, and it literally does nothing but breed resistance. And antihistamines, they just dry out the mucosa without doing a single thing to treat the underlying viral inflammation.
Breaking down those approved targeted therapies a bit further, the data is really clear. Nasal saline irrigation, whether that's a simple spray or full-on douching, is actually a grade A recommendation. It physically flushes out the nasal cavity and works wonderfully. Analgesics effectively handle any mild pain or fever to keep things comfortable. Intranasal corticosteroids, they're optional, sure, but they can be a fantastic tool to reduce mucosal edema. And finally, the guidelines emphasize a very strict rule on decongestants. They are reserved only for severe obstruction, and they absolutely must be capped at a maximum of 5 days. That 5-day limit is crucial to prevent rebound congestion, clinically known as rhinitis medicamentosa. We definitely want to avoid that.
Which leads us to a final thought. The next time a patient sits in your clinic, visibly frustrated and outright demands antibiotics for a 3-day sinus infection, how will you use the EPOS 2020 criteria to explain the science? By relying on the framework we explored today, the specific timeline, the total lack of double sickening, and the strict symptomatic-only guidelines, you can confidently educate your patients, skip the unnecessary antibiotic prescriptions, and provide top-tier, evidence-based care. Thanks so much for exploring the data with me today on The Explainer, and I'll catch you in the next one.